cheek, hollow cheek, 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 hollow cheek, cheek, cheek. Cheek, cheek, hollow cheek, cheek.
इसमें सर बोलते 39 years female going to intubate, weight है 59 आ रहे थे, ठीक है ना, 59 kg।
लैरिंगोस्कोप दीजिए, सुपॉल दे दिया, दीजिए, लैरिंगोस्कोप दीजिए।
Dr. Sajad on the patient head in, going to intubate the patient।
लैरिंगोस्कोप दीजिए ना, अरे यहाँ से निकला अभी तो यहाँ निकाल कर रखा था यहाँ यहाँ रखे कहाँ है
लाइए,
दीजिए सर।
पानी चलाइए।
ये केस ऑफ टिम्पेनोप्लास्टी नहीं, for tympanoplasty we generally give the general anesthesia। on serious
पानी चलाइए तेजी से।
इस सुपल दे दिए ना,
सुपॉल दिया है,
टिम्पेनोप्लास्टी सीरियस नहीं होता है।
हाँ लोकल सेडेशन होता है।
सर्जन कैन डू इट इन लोकल एनेस्थेसिया आल्सो, लेकिन इसमें ये बोझ नहीं लगाए। लीजिए,
कौन साइड का है? राइट साइड। बोला दीजिए।
Sajad intubate the patient with armor tube, 7.5 number cuff armor tube। We choose the armor tube. It is a flexible tube. In positioning, there is no kinking of tube. There no kinking of tube. So we choose armor tube। Armor या other name of this tube is flexometallic tube। इन फ्लेक्सोमेटालिक there is no kinking of, देखिए कितना भी किंग करेंगे तो ये होगा नहीं किंग, इसलिए ये इसका एडवांटेज है, ये आता है। कैमरा चल रहा है मास्क तो दे दो। हो गया है। अभी सर को देते।
हाँ हाँ ठीक है।
बाकी का ये तो सब अपने एक्शन है, थियरी को ये वाला यहाँ पे बोल दिया, तो आपको नोज भी करना है, फ्रंटिंग भी करना है, ये जो है यहाँ पे जब आपको लगता है, बाकी ज़्यादा तो लगता है ये वाला काउंसिल में इसमें करना है। तो ना लोकल इन्फिल्ट्रेशन दिखाएंगे, ठीक है, नो प्रॉब्लम। कितना है?
सर का माइक
हेलो हेलो, 30-year-old ना? हेलो 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 ऑडिटोरियम, हेलो इसमें फोकस हो रहा है, एक पूरा ऐसा, इसको एक हाँ नहीं पूरा हो रहा है, एक एक को हम दिखा सकते हैं, हाँ एक दो या फिर इसको करें, हाँ। हेलो कैन यू हेयर मी? Hello. A photo is going on.
Good morning, sir.
Hello auditorium, Dr. Raibat, Dr. Vineet, hello.
Hello.
Yeah.
Sir, Dr. Raman बोल रहे sir.
Yeah.
Good morning.
Good morning everyone. So today sir will demonstrate the live case. So we are requesting Dr. Ashwini Verma sir to kindly chair this session along with Dr. Farooq sir. Farooq sir.
Sir, Dr. Soni sir and Farooq sir will be joined later. They are in dissection hall. They are observing the dissectors who is doing temporal bone dissection. So they will be coming in this hall within few minutes, sir.
Okay, sir will start the case. Now he will discuss the CT scan and a brief clinical history. Over to you, sir.
Hello. Hello.
Prince, till then you can chair the session.
Yeah.
Dr. Prince.
Yes, sir. We are audible here.
Okay, okay.
Okay. Good morning, everyone. Prince. Good morning.
Morning.
So today's case is a 30-year-old female having a bilateral ear discharged since 9 years. On audiometry, the right side is a 20 dB airborne gap, and then there is a large perforation and some small tympanosclerotic plaque. Left side also chronic discharging, that's a little bit discharging here. So we have planned for the right tympanoplasty, and we will try to correct the disventilation because this patient is discharging for the 9 years and right ear is just now it become a dry. So there has to be some ventilation dysfunction. So we will correct the ventilation dysfunction. Yesterday you have seen all the middle ear anatomy. Try to correlate it today with the live surgery. So I have demonstrated you yesterday the all middle ear anatomy and the anterior isthmus, posterior isthmus and the tensor fold and all. So the patient's CT scan is, this is a right CT scan. Typically the CT scan for that safe type of disease, I hardly do CT scan, just a X-ray mastoid can be done to assess where is a tegment plate and where is a sinus placed, or whether there is an contracted mastoid. So I usually go for the X-ray mastoid. If you suspect some polyp, if you suspect some cholesteatomas and some erosions and all, so then you go for the CT scan. Typically for the CT scan, we ask for 0.5 mm thickness plates. So unless and until you get that, you will not assess what is happening in the middle ear. But roughly you can see how to read the CT scan. So start from the above. This is the sagittal sections. Hello? Hello? Prince?
Yes, sir. We are.
Yes, yeah. So the CT scan is there?
Yes, sir.
Yes. So these are the axial sections. So how to read? So go from the up to down typically. So it will be easy to understand the structure. So if you take a slices from up to the down. So first you will meet the superior semicircular canal. After that you will meet the posterior semicircular canal. Then there is a lateral semicircular canal. When the lateral semicircular canal comes, you will see in the epitympanum the typical ice cone appearance, that is an malleolar incro joint. So if you start from here, so this is from the upper section. So you can just see the start of the mastoid. Okay, it's nothing. So if you come here, note this. This is the right side. This is superior semicircular canal. Can you see that?
Cameraman, kindly focus on the.
Please focus. So focus here.
Yes, sir. Now it is visible.
Yes, you can see this. So if you start from above, the first thing to come is superior semicircular canal. So this is a dome of superior semicircular canal. The next section, this is I think 2 millimeter section. So there are, I can't comment much about it, but roughly you can come to know what is there in the middle ear and what is happening in the mastoid. Okay, so this is a dome of superior semicircular canal. Then come the next section, you can see this too. This is again a superior semicircular canal. These are, this section is going through the superior semicircular canal. So this is anterior and this is posterior part of the superior semicircular canal. Again here it is superior semicircular canal to ampullae, and then there is a start of the mastoid. Still there is no posterior semicircular canal in the next section. So I am coming from up to down. So please go from here to here. Okay? Yeah. It's visible?
Yes, sir. This is
yes. So now note it. You note here. Anterior end of the superior semicircular canal, and then posterior end, and the start of the posterior semicircular canal, the dome of the posterior semicircular canal. Can you see that?
Yes, sir.
So you can see now the mastoid here. Mastoid is clean. Okay. So
yes, sir.
Black thing, that is, there are only iso, hyper. Okay. I think so here it's an air only. So that's no soft tissues. So mastoid is clean. Still I am going to just explore doing the atticoantrostomy, a little bit of atticotomy to peep inside if possible. If everything is clean, then I will not go for the atticoantrostomy in this case, just simple type 1 tympanoplasty, because the airborne gap is less than, there is around 20 dB. So coming back here, again the posterior semicircular canal and the start of the lateral semicircular canal. Look at this, okay? Typical signet ring appearance. Can you see this?
Yes, sir.
Yes, and then behind there is a posterior semicircular canal. Okay. The whole of the mastoid is here and the start of the epitympanum here. So again the mastoid looks clear, okay? This is an hypodense. This is typically you have to compare with the brain. This is an isodense. Hyper means this is a bone density. So comparing this air is hypodense, so that's an air. So if the soft tissue is there, it will become a isodense with this compared to that of the brain tissue. So you have to compare with the brain tissue. So there is no soft tissue here. Coming next level, that's we are coming from up to down. Now you note here lateral semicircular canal, and typically in the epitympanum you can see some ice cone appearance.
Yes, sir.
Can you see this?
Yes, sir.
Can you appreciate that?
Yes, sir, we can.
Yes. So here is an ice cone appearance, so incodo-malleolar joint. And again you can see in the epitympanum, which is formed by the anterior and the posterior epitympanium, it's clean. It's an isodense. Coming down, you can see the cochlea. This start the cochlea, and then again in the epitympanium, it's an isodense. So there is no cholesteatoma or no polyp, nothing, and even not some collection also. So looks and clean case. There could be a simple disventilation syndrome. Rest, if you see, there is nothing much here because these are 2 millimeter section. So just I have given you the rough idea how to read the CT scan. Go from up to down and start seeing the dome of the superior semicircular canal, then see the posterior semicircular canal, then a lateral semicircular canal typically. You can note also, if you take up 0.5 mm, you can see some erosions, you can see the fistulas if the cholesteatoma is there, and you can decide whether there is an erosions with the cholesteatoma in the mastoid. Okay, is it clear?
Yes, sir.
Yes. So with this, I think a little bit I will show about the endoscope holder. Can you focus on this? Yesterday you have seen that patient is been prepared. Now can you see the endoscope holder?
Yes, sir, we can.
Yes. So yesterday you have seen this is an endoscope holder called EndoHold GS201B, which can be fitted to your operation theater table. We have the other model also, which is called the floor model, like as your microscope. So it has got the vertical arm, it has got the horizontal arm. Horizontal arm, if you can see, so it rotates. So idea is to rotate. So now the shoulder, so this action. So it has got the all action because you need to have this action. Without these actions, you can't carry out the surgery in the ear properly because you need those motions, even for the nose, even for the throat. So we apply this endoscope holder for all ear, nose and throat. So vertical arm, which is gripping your operation theater table, and then there is a horizontal arm which rotates almost 360 degree. Look at this. Okay? So you need this type of actions. You can't have just as a fixed endoscope holder. You can do certain steps, but it will be a very cumbersome to carry out the otological surgeries. I mean all otological surgeries. In my OR, I don't have any microscope. I carry out each and everything with the endoscope holder. Let it be a small, simple perforation, to the extensive cholesteatomas, to the canal wall reconstruction, to the complicated cases. Just for the cholesteatomas and the revision surgeries, I take a mini end oral incision. Yesterday I have demonstrated that. Here I will be doing it with the trans canal because it looks like a clean, healthy middle ear. So just take an end oral and then carry out your work. So yesterday I have described and shown you that end oral incision. So after this horizontal arm, this is an important aspect of endoscope holder. It has got the gas spring. So with this gas spring, you can take anywhere. So now this action is this. Okay? So wherever you go, it will stay there. This is a balancing screw. If you balance it properly, wherever it is there, it will go and stay. If you don't balance, it will either fall or it will go up. So you have to balance this. That's also by rotating clockwise and anti-clockwise, you can just balance. If you want in a fixed direction, come into the one position and you can lock this also. So once you lock it, it will not move anywhere. Okay, see this. For certain positions, when you want to do in a tonsil or larynx, and in a fixed position, if you want to do some nasal surgeries, you can apply this. Otherwise, keep it in free. Wherever it will go there and stay. Okay, so that's an horizontal arm. Now this action has been there. Now this has got the multiple joints and the actions. This simulates the wrist. Okay, so first thing, this. So we use this much only. We don't use almost all 360 whenever you are operating because our cavities are small. So you need only a 180 degree maximum in case of the throat surgeries. In nose, hardly it is a 45 degree. For the ear, it's a hardly 10 degree motion is needed. This and this much. Okay? So you can fix it also if you don't want. Otherwise, keep rotating like this. After this action is there. Now this. Okay, you are using all these actions. This has been simulated here. Got it? Hello?
Yes, sir.
Prince.
Appreciate it. Yes, sir, we can see the both
Yes.
the side
So,
movement.
so understanding this, if you understand this, then there is hardly anything to learn from this. But you have to know and you have to use these actions. You can't just keep the endoscope holder in one position and keep on doing the surgeries. Okay? So this is this action. So this shoulder action has been simulated. Then 360 degree we have seen on the horizontal arm. Then gross action of up and down, and then this 180 degree motion is this, and then this action. Yes. Yes.
Good morning.
Good
Good morning. Dr. Farooq here. Dr. Farooq.
Good morning, Dr. Farooq.
Sorry for being here late.
No, if the cadaveric dissection is going on, then there is no problem, because you have to teach the students.
Ashwini boss is here.
Ashwini boss, good morning.
Good morning, dear.
Good morning.
Sorry for
How
being late.
was the journey?
I will enjoy your surgery now. ठीक. आप सर्जरी करो, हम देखते हैं.
Yes. So just explaining the endoscope holder and this action, this is this action. Okay. So once you lock this, now this action. Whenever you are working into the throat, whenever you are working into the larynx, you need to do the rotation. In ear, we don't need that much. In ear, what we need is this much motion. That's all. Just a 10 degree to 20 degree, nothing more than that. So you have to understand this. Don't do all these gross motions in the ear. So just simple motion in the ear. So that much is needed for the ear. If you want for the throat, for the nose, then you need little bit of more motions. You can typically use this. So whenever I use this typical position for the septoplasty, for the nasal surgeries, and when I want to do the larynx or the throat, so completely like this. Endoscope is here, and then you try operating with this. Okay? So these are typical actions which has been simulated. That is almost your left hand is simulated in the ear. So one day this will become, now this is a mechanical one. One day these all motions will be controlled with the electric motor, and this will smooth, it will become a more smooth. But at present this is ergonomically a mechanical one. Okay? Got it? So once you are in the ear, this gross action is not needed. So once you have positioned the endoscope is here. Rafiq, can you mount the endoscope? Rafiq, can you mount the endoscope? Required, and this is a patent with coordinates bracket and while to and now this whole the endoscope at present this holds the small endoscopes and some other company all even the strike by make of endoscope. Those are then we provided the provide magic lamp to just remove part and attach that part. And you can any type of endoscope. Now we are trying to use the 10 millimeter and instead remove this as this.
Clear.
I hope it's clear. Any question? Private eye operation. You can carry out any time your surgery work, and my patient demands GA only. So now all the cases in my OR is under general anesthesia. Okay, thank you. I will just get washed and I will show you the infiltration there. And yesterday I have demonstrated the cartilage harvestation. That also today you try to correlate it. And here I am doing transcanale. So I think the case should be finished by 1 hour. Okay.
Meanwhile, sir is getting scrubbed. Now, I request our HOD sir, Dr. Dharmendra sir, to kindly welcome all the delegates for this 12th live endoscopic ear surgery.
Good morning. Welcome to all delegates and chairperson and AY secretary and president. Today 12 ENT live surgery workshop started. Dr. Mubarak start right side tympanoplasty under GA by the endoscope. Thank you. Welcome to Ashwani Burma sir. Today moderate the session.
Thank you, dear. Thank you so much. Although I don't deserve any thanks because I am late.
सर लेकिन आ तो गए हमको लग रहा था कि नहीं आए थैंक यू सर अश्विनी सर आने के लिए थैंक यू ठीक है थैंक यू
कौन से मोड पे डाला है So already the endoscope has been mounted on the endo holder. Just look at how it is mounted. It has been mounted with the neck. This is our endoscope, that's called E-scope. This is a 3 millimeter endoscope, 18 centimeter length. Before going for that, adjustment is very much needed. You have seen, clean your endoscope properly, get white balancing done, okay? And then obviously you need a wonderful system, and here they have the stars, this spice camera. It's a nice one. If you use that, you will enjoy the endoscopic ear surgery. So minimum requirement is in high definition camera. Don't try to do the endoscopic ear surgery with a single chip camera or whatever those OPD units are there. You will lose the interest. Otherwise, don't do it. Use the microscope. That's a simple thing. You need to have the high definition cameras or 3 chip cameras. So whatever 3 chip camera you want use, but Storage is one of the best for the, they have a different modes and you will see the beauty while doing the endoscopy. Look at this. So why endoscope? This is an panoramic view what you are going to get it. So before going, I am going to show you the infiltration also for the juniors. So for every cameras you have a different setting. With this image 1S, these basic things are also not, we don't know. So here it has got zooming. I love that zooming of Storage. So look at this. So they have provided here only. This is the minimum one. So you get a complete here. When you do it, look at this. Look at this zooming. Okay, this is a maximum. So whenever I want to do the drilling and all, I use it as an exoscope by keeping the endoscope little bit away. Before going to that, do the white balancing because that color contrast is very much needed. Different camera system has got some different requirements and just refer to their user manuals. So before going for that, let's get oriented. You are seeing this here with the microscope. Anatomy is same, but with the microscope, it's a different orientation. With the endoscope, it's a complete panorama in front of you. So the anatomy, you need to master a little bit with this called endoscopic anatomy. Can you give me the ballpoint? Please feel free to disturb me because asking question is knowing for all the juniors. So tragus, I will be harvesting the tragal cartilage from here. So you have to preserve this. This is a female. So for everyone, you have to preserve this 5 millimeter for the better cosmesis. Yesterday I have shown you this is the area for incisura terminalis, area for end oral incision. Once you pull the ear, just look at this. Before this, we usually clean the ear apply the wheat cream to remove those all hairs. Now this has not been prepared, so I will just shave it little bit and then later on I will go. Now this ear is collapsed. Typically in OPD, you just pull pinna outward and backward. Why? Because you are straightening the canal. The same thing is needed for the two-handed endoscopic ear surgery. If I pull, look at this. If I pull, you are going to get 1 millimeter more. So by just pulling, here the eardrum is not seen. I am keeping the endoscope outside the ear canal. Once you pull, you are going to see inside, right? So I am going to take a stay suture called Therabasis suture. Yesterday also I demonstrated that. I will show you. Let's go inside to do. Can you see that? The perforation and then there is a mucosalization. Look at this. This is all mucosalized.
Hello, Dr. Mubarak.
Yes, sir.
There is a confusion.
Yes.
For me, I am totally confused using this term mucosalization.
Yes.
Is it really mucosalization or is it just granulation?
Very good question.
Mucosalization has a hyped matter. It is never a mucosa.
That's a matter of discussion. But
this area, this condition with simple glacial elastication and steroid, this granulation goes away. Mucosa cannot you cannot destroy mucosa with normal glacial.
So how you will proceed for that? Will you freshen the margin and just keep the graft here?
No, you should remove it completely because in this is basically granular myringitis. Granular myringitis is being wrongly quoted as mucosalization.
Yes, that could be the possibility, but this is the long-standing disease, so could be this granulation. See, look at this. So you have to remove all these things and then do the nanoplasty. Let's go inside and see. I am going inside. Can you see the handle of malleus and the umbo which has completely retracted? I am going through the perforation. Yes. So this much I can go. So let's take the, first we will do the infiltration. Till that time, little bit of this hairs has to be removed, because whenever this touches to the endoscope, it blurs the vision. Give me the, I will unpack soaked within. So first I will shave this. In our private, what we do is that one day prior we apply the wheat cream, that is a hair removal cream. This we are doing for the last 10-15 years. Don't worry, there is no reaction to that. This wheat isn't trade name of that cream. But previously we used to apply the any French, but that gives some reaction. So use this wheat cream is there. So one cream goes for you for the 2 months, 3 months, okay, for hundreds of cases. Just apply it in the external auditory canal, wait for 10 minutes in OPD, and all hairs are just removed with the Jobson horn probe, okay. So many of the time when you are doing the shaving, due to the tortuosity of the canal, you are creating the abrasions. So that's why we use those hair removal cream. Okay? And by this way, many of the time a few hairs fall there. So that's why I have put some that Merosil pack inside, which are soaked with the xylocaine with adrenaline, so that it will not fall in the middle ear. Those small things can improvise your results. That's better. Yes. See this, by just pulling the ear, how it becomes a straight one. So first we will do the infiltration. I need tragal cartilage, so even I will be infiltrating xylocaine with adrenaline. एक गॉज पीस, नीडल थोड़ा बढ़ा दे देना, 26 नंबर और 1.5 इंच रहेगा तो दे देना. तब तक दे दो उसको. Use a 26 number needle with 1.5 inch length. So first tragus. I am infiltrating the tragus because I will be harvesting the tragal cartilage. Can you see the blades? As I am not going to take an end oral, so I am not going for the infiltration of temporalis fascia. If I take an end oral incision, then even I infiltrate that too. Now some longer needle. Posterior canal. Suction. ले लो थोड़ा. Always wait for some time after the infiltration so that that effect will come. I will infiltrate the still a posterior canal wall and give me this. Those hair troubles you, so that's why you have to take just a 15 number blade. You know? Give me the. Now there is no 26 number needle here. Take 26 number better. So in a vascular strip you start because there is a lax skin, so you can do in a better way. Yes. That's in a posterior superior area. Suction please. And then do everything under the endoscopic control. You will do it nicely. Anterior wall. Better. Then little bit of inferior wall. It's very thin skin. You have to preserve this, very important. Because from here the squamous epithelium is going to grow. Look at this. Yeah, better. And some. Now again keep some, I will unpack. Instead of that cotton wool plages, I use the Ivilon pack or the Merosil pack which you use for the nose, so that you will not leave anything. So this is nothing but this is a sponge, nasal sponge. So soaked in a xylocaine with adrenaline. Why to use this? Because when you are using those cotton plages, you leave some lint behind, and that could be the reason for some failure. That 0.11% may be the reason for that, and we have noticed that the typical granuloma formation in the middle ear sometimes. So wait for some time till that it acts. And what is the blood pressure and what is the pulse? BP और pulse कितना है? हाँ? Yes, और थोड़ा सा pulse को अभी adrenaline दिया है लेकिन थोड़ा सा बात अभी नहीं, अभी थोड़ा सा एक 5-10 मिनट देखो, because adrenaline देने की वजह से होता है. Then you till that time we will take the stay suture. So the stay suture is nothing but a stitch in the posterior canal to just pull this. So give me the here. This is one. So this is a long needle. You need to have a long needle like this. Okay, so this is a 10. This black silk. or simply you can use a needle with a 80 number or the 60 number tonsillar thread. Okay. So here I need only a one stitch, otherwise see this is a right ear, here it's a 12, here it's a 6, here it is a 3, here it's a 9. So I will be going at the 9 o'clock position at the junction of bony and cartilaginous junction. Okay. And for if the canal is wide and we want a good retraction, so Dr. Sapna has modified it. She takes at around between 9 and 12, that is 10. So 10 and 11 she takes one and another here between at the 7 o'clock and then retract it. So let's go, this is a little bit of bigger needle, but can you see that? I am going slow so that you will understand it. So I have just taken these. And it comes like this. See this, okay? Understood?
Very clear, dear.
Yes, thank you. So now the pulse is at around 88. Don't be hurry, okay, because we jump. There is some physiology, okay, whatever drugs you are using, the body is responding to that. I have used the adrenaline just as an infiltration. Obviously, there will be a reflection in the pulse. So it has raised to 90. Now it will settle down little bit. So till it settles to the 80, don't jump it, okay? Or otherwise ask your anesthetist. They adjust that dexmedetomedium or something like that. बराबर ना? तो वो उनका काम है. तो वो now the anesthesia has become very nice and beautiful, and you can carry out the surgeries like anything with the hypotensive anesthesia. And the comfort and the ease is the all what is needed for the beautiful surgery. And now you can achieve that with the good hypotensive anesthesia, because I know when I was doing my residency, only the anesthetic agent at that time were ether. And I have seen also the open anesthesia, and there was sodium pentothal. Am I right? Yes, yes. The sodium pentothal and the ketamine, and there are so many, and it used to cause many problems, and now it has evolved from that halothane to sevoflurane. Yes, and so life is very easy. They have those beautiful drugs of propofol, and also why not? My anesthetist charge hugely for my giving this anesthesia in my private, but I am happy to pay him because he gives me the comfortable and the ease during the surgery. So I think this little bit settle, थोड़ा सा पल्स को अगर कम करेंगे तो और अच्छा रहेगा इंसिजन लेने के पहले. 4 सेकंड. सक्शन. इसको थोड़ा सा इधर इसको ऐसा लेंगे इधर थोड़ा सा, जस्ट मॉनिटर को मेरे सामने थोड़ा या इधर इधर और थोड़ा सा, बिकॉज ये बीच हाँ जस्ट एक थोड़ा हाँ ढकल हाँ ये सक्शन को हिला देंगे थोड़ा सा, या मॉनिटर को भी सिर्फ हिला देंगे इधर तो चलेगा. थोड़ा सक्शन निकाला हलेगा या नहीं, थोड़ा पीछे ही जाना चाहिए बिकॉज बेटर. Look at it after decongestion, it's quite good. So little bit of zooming I will do. So let's go inside. Anterior overhang is there, but it will hardly matter for me because endoscope is there. Clean it everything. This all. थोड़ा सा हेड को लो करेंगे because this flexion हो गया है थोड़ा. Position. कुछ शोल्डर रख सकते हैं?
नीचे शोल्डर में टॉवेल होगा.
छोटा सा एक टॉवेल रखेंगे.
छोटा सा टॉवेल शोल्डर के नीचे.
बिकॉज हाँ.
छोटा वाला.
हाँ गाउन चलेगा, वो नहीं, वो बहुत ज्यादा हो जाए. क्लीन. So now first remove all these things, because if this enters and remains there in the middle ear, again that's a reason, because external auditory canal is full of commensals and commensals are pseudomonas. Okay, so why our ear fails? So we think that these are the reason. Whenever you are doing the cleaning, even a clean kar hai, don't just push all the dirt inside. Go down and then let the things come up. Just 1 minute. So when you are just coming and pushing, this all squamous epithelium, some dirt, the wax can enter inside. Okay? Yes, I'm just changing little bit of position. I need some little bit of shoulder. कैसा करेंगे थोड़ा सा, क्योंकि आपका रिंग जो है काफी बड़ा हो गया. इधर चाहिए, शोल्डर में चाहिए मुझे. हाँ, इधर से बेटर रहेगा. हाँ, एनेस्थेटिस्ट कहाँ है? एनेस्थेटिस्ट कहाँ है? वायर उधर देखने. क्योंकि ट्यूब नहीं हिलना चाहिए. चला. सो जस्ट हाँ, शोल्डर के नीचे डालो, पूरा सिर्फ शोल्डर के नीचे चाहिए. हाँ, या जितना शोल्डर के नीचे जाएगा उतना अच्छा है. ओके, या थोड़ा ज़्यादा हो गया शायद. जस्ट हाँ, ठीक है, कोई प्रॉब्लम नहीं है ना. Suction, छोटा suction. Still that small thin debris is there. Take that out. So if you push this inside, so this is the reason for the failure. So simple tympanoplasty is not also just elevating the tympanomeatal flap and putting some graft there. Okay, you have to take care of all these things. Yes. छोटा section रहे, फिर है मुना सा. So let's freshen. There is no anterior margin. So I will boldly take this. Can you see this? So as Dr. Ashwini was saying, this could be the granulations grown over that, and down there is a eardrum. Look at this.
Yes, yes, down there is drum.
Yes, so उसको साफ कर देंगे पहले सब पूरा गया. So if we can preserve that, look at this, okay?
But Mubarak, it is said that this is also a cause of perforation.
Cause of?
Long standing chronic meningitis may lead to tympanic membrane perforation.
Yes.
And there are a lot of etiologies. Suppose some are saying it is infective in nature. Some say that it is due to autoimmune nature. But it is never epithelial mucosalization. Mucosalization is totally wrong nomenclature.
Yes, we have discussed this so many times, right?
Yes.
on many groups.
I am fighting against all of you.
Yes, and you fight like anything, and I agree with that many of the times. So down is the nice eardrum. So इसको मैं पूरा clean कर रहा हूँ. That's nice granulations. Caesar. Now you can see the malleus there. We will throw that out, it is better. उसको पूरा exercise कर देंगे. Cecal. Because I am not happy with that eardrum. These are all granulations, so better to throw it out. So it has become a subtotal perforation now. Give me xylocaine adrenaline pack. So we will keep a small pack and then we'll take a flap. थोड़ा सा पल्स कम करेंगे ये थोड़ा सा जस्ट थोड़ा सा सर्कुलर so very thin, so start from here already, so try measuring from here. So if you make a very small incision, it is very easy to elevate. But now I want some good flap because it has become almost a subtotal to near total perforation. So I will start from here.
Hello?
Yes.
Any criteria for giving incision at which site?
Yes.
What is the actual distance?
Yes.
Is it even for you or it is very fixed? Just on the matlab ki hair bearing, non-hair bearing area?
Yes. That's a very good question because I modify accordingly. See, if it's a near total or almost a total perforation, we need to have a good flap. This flap is very important, and many of the time it's very thin flap. If it's a thin flap, you give it at the junction of vonia and cartilaginous junction, it's really little bit tough to elevate from there, but good flap gives you a good healing. If it is a nice skin and you are sure that you can elevate everything, so I just make it a typical Rosen's incision. And for the end oral, typically at the junction. So take a time for this because it's very important to elevate the flap. I hope the picture is good there because I can see a very nice picture on the screen here. Hello?
Yes, dear.
पिक्चर अच्छा है उधर?
हाँ पिक्चर अच्छा ही है. अब मॉनिटर वाला पिक्चर तुम लोग को मिलेगा नहीं. We cannot get the class.
Yes, yes, that's true. You know it better.
Actually, picture on the monitor is entirely different from the picture what we get in the auditorium.
Because this output is very high from all these high-end cameras.
Medical grade monitor has got different resolution. They have got different technology. Even best of the best TV which you put, that they cannot just equal to the medical monitor.
Yes, last time I was operating on a 4K system, and that audiovisual guy couldn't give that image down there. 4K has got completely different.
4K TV, even if you put 4K TV in place of your monitor, that will just ugly. Very fat. So whoever are using monitors, using endoscope, they must use monitor, medical grade monitor.
So take a time for this, don't be hurry because that flap is very important. Here it's always a tough because it's a vascular strip, thick skin here. Start from there so you will not traumatize the flap. Use the suction meticulously. If it's a thin skin, the whole flap comes in your suction.
Actually, Mubarak, I think we should have very disposable knife for giving very sharp cut.
Absolutely.
Horizontal, what you call circular knife, they don't work. They work just by pressure. They don't have any sharp edge. They are not very fine.
You can see the Arnold's nerve. This is Arnold's nerve I am cutting. The branch of vagus. Many of the time during the OPD when you are removing the wax, this patient gets a vasovagal due to the stimulation of this now. Now I'll use the small because the canal is only 7 millimeter. Put that. And give me a smaller circular. This bleeding little bit is expected here because this is a chronically discharging here for the 9 years. So that local whatever granulations we have seen and the inflammation which is going on there, that usually gives this bleeding. So I am reaching to the annulus. This is a scutum. I have come from above. Let's make some picture crispy. So note the difference between the single hand and the two hands. The suction is taking care of that small bleeding. It is taking care of the heat which is generated in the EAC. I have reached there, so इसको निकालेंगे अभी flat, so that you will understand the annulus. So give me the forceps. Very narrow canal, but still you can manage here because it's a 3 millimeter endoscope I am using. थोड़ा सा zooming. Okay. Smaller circular for the, look at the angle which I have given to the circular. Okay? Yesterday I was showing you that. So this is an anterior wall, this is a posterior wall, this is a superior wall, inferior wall, typical position, because I am originally a microscopic surgeon, so I love this position only. So can you see the annulus?
We are not getting the picture.
No picture?
Hello, audio video.
Audio visual.
Picture नहीं आ रहा. Yes, now it's there.
Yes. So can you see the annulus here? Look at this.
Little bit bloody थोड़ा.
Yeah, थोड़ा सा उसकी कॉटरी लगाएंगे, कॉटरी लगाए. So we have that suction cautery. We have a suction cautery too for the ear. So for this flap we can just do a small cautery, so the small bleeding will not be there. Unipolarly. So let's go slowly and let the make a field good. Suction. So you can see this. Can you see this?
Yes.
Yeah. Just insulated small suction. लगाओ. Never use this in the middle ear. This is only for the external auditory canal. Okay. Better.
Cauterizing it.
Yes, sir.
Do you use monopolar cautery very frequently?
Yeah, whenever this for the external auditory canal flap only, and outside, not in the middle ear.
Because Dr. Ahila is using his own knife, circular knife.
Yeah, but that gives that's a problem with the healing, and there is a granulation which is formed. So now it's better.
Much better.
Yes. So let's go near. Give me the flag knife.
नहीं इसका कोई.
सिकल दे दो पहले. Nowadays I use extensively the PRF sheets for rejuvenating this chronically inflamed mucosa, and that works fantastically. Give me the flag knife, angled one. Look at the angle. Now I am just elevating here till 3 o'clock, just undermining it, okay? We'll go from here now.
क्या सर
Yes.
मंगा सकते हैं आप
Hello.
हाँ yes
You are asking something?
no chorda tympani is visible.
Yes.
I think there is bipolar forceps for otological purpose is also available.
Yeah.
But it is very costly. But for Mubarak it is cheap.
Yes, sickle.
Yeah.
I am in the Prusak space. Can you see the lateral process of malleus?
Yes.
I can see the incodostapedial joint.
Yes.
Now let's elevate this. Forceps, please. Better. Sickle. थोड़ा सा एक फ्लश दे दो तो पिक्चर और अच्छा दिखेगा. Normal saline. Even typically here we use a ringer lactate, little bit more physiological. No study. We're trying to do the study by keeping this tissue in a normal saline and then ringer lactate and measuring something. So let's see. So again, point, just go down and then irrigate. Don't just push from up because you are pushing the all dirt inside. So go down, let this free flow come from down. Sickle. I will take a periosteal incision on the malleus. First remove this, there is a merosil pack. So it's good flap.
Yes, sir.
Whenever I am using my instruments, I am using the external auditory canal as a fulcrum, okay? That's why those tremors are not there. That's an important point. And I am resting my two fingers. So don't work with your shoulder, just work with the wrist. Clean. Yes, that's better. Just now, again, circular or the flat knife, whatever. Now you need to use the suction judiciously. Okay, if it comes in, I have I have removed the finger from the hole over the adapter, so the pressure will be less and the flap will not get sucked in the suction. the sickle. Sickle. There's a part of annulus. In the inferior part, rest annulus is gone. So we'll put here. Yeah, better. Give me the sickle. Anterior isthmus. Just trying to take out the some.
Anterior isthmus, this is?
Come again?
This is anterior isthmus, sir.
Yes, this is anterior isthmus. We will go and see near. First, let me denude the malleus. Already it has been elevated. Yes. At the umbo. Yes, many of the time if it is not able to come, so I use a malleus snipper. But you have to use it very judiciously, otherwise the malleus becomes hypermobile. Give me the forceps. Hope my forceps will work. I'm just trying to take out the small fibrous layer there. Yes? Okay? Yes.
Yes, sir. Yes, sir.
Look at the beauty of the endoscope. Okay?
Yes, sir.
It's clean. I can see the both crust, but I will, just for the sake of demonstration, I will remove a little bit of posterior superior canal wall with the curate. Thoda sa normal saline. Curate. Again, I had told you how I have bent it. Just for sake of demonstration, not needed because it's a clean here. What I can see is nice mucosa. If there is a polyp, if there is an hypertrophied mucosa over the promontory, then I try to take out, do the aticotomy. You need to be very gentle. Never do this action, otherwise all your ossicles go. Just across the bony annulus.
Yes, sir.
Hard bone, because this is a chronic inflamed ear, so obviously the sclerosis. Yeah, better. With endoscope you can peep inside, so that's why no need to remove, but just for sake of demonstration I am just doing this. Again some flush. I will take out this all mucosa also. Give me the circular, which is in the retrotympanum, so that it will not grow again. I mean this. Just see this, hypertrophied mucosa. Because if you put a graft there, the mucosa will grow again. So take it meticulously. Better. And the hypotympanum. I will put some xylocaine adrenaline pack and I will show you the middle ear. What is anterior isthmus, what is posterior isthmus, where is the tensor fold, and then I will go for the harvesting the tragal cartilage. So let's achieve some little bit of hemostasis. Look at this. These are the lint which are from the your towels. Okay.
Yes, sir.
So due to the repeated, so this you have to take care. With the endoscope you are able to see everything. One more.
So what solution you are using in gel form?
That is xylocaine with adrenaline. So just 1 minute we will wait. Till that time we will assess. We will be harvesting the tragal cartilage there. Just a gauze piece, wet gauze piece. Clean करेगा ये endoscope ना. And then we will do the endoscopy. And why endoscope, then you will understand. Just to inspect the middle ear, just to see the patency of anterior isthmus, see the patency of posterior isthmus. Mainly if you achieve a patency of anterior isthmus, which is a ventilation source for whole of the epitympanum as well as the whole of the big mastoid bowl, it's 80% from there. So the air which is coming from the eustachian tube, it comes to the mesotympanum. From there it goes to the anterior isthmus and the whole mastoid is ventilated. A 20% ventilation is through the posterior isthmus. Anterior isthmus is in between the processes cochleariformis and the long process of the incus or the body of incus. That one small channel is there. I will put a ball point and you will see. Many of the time what I do in case when this, there are polyps, small polyps, there are like this typical polyp, like osteomeatal block. There are some small polyp coming out, some serous discharge coming out, glue is coming out. In such situation, I just irrigate it with the dexamethasone and I see whether the fluid is coming from the posterior isthmus. One, in such situations, not here, but in those situations where it is blocked, I open the tensor fold. I try to see whether the flow is coming from the tensor fold area. I put the irrigation from the tensor fold and see whether it is coming through the anterior isthmus. So this is the way you can just assess. So that makes a functional endoscopic middle ear surgery, not just a simple tympanoplasty. Okay, I hope it was achieved, and I will show you how to open the tensor fold too to achieve some extra ventilation. But considering the CT scan, this is a good ventilated mastoid, so need not to do much. Just for the sake of demonstration, I will open the tensor fold. Yeah. Now that's good field. So that small waiting time makes a hell of difference. Ball point. Now they have given a wonderful BP. So pay very nicely to the anesthetist. They will be. My anesthetist charge hugely, but I am very happy to give. And patient is also comfortable, right? See, above all, the surgeon is comfortable. और सर्जन का ब्लड प्रेशर कम रहेगा, सर्जरी बहुत बढ़िया रहेगी, ब्लडलेस सर्जरी रहेगी, राइट.
We are thankful to Dr. Anil sir and Dr. Sajad sir for providing hypotensive anesthesia. You can see the BP is 92/56.
दिखाओ उधर. हाँ. And वो मेरे तरफ से उनको कॉफी.
Yes.
Okay.
Heart rate is also 75.
Perfect. This is a perfect scenario. Okay. So let's go down. So focus. Yes. Anterior wall, superior wall, inferior wall down, and posterior wall. Lateral process of malleus eroded, long process of incus little bit eroded. In such situation, my PRF works like anything. I just keep a PRF sheets over this and then do a tympanoplasty. So the area here, this is a supratubal races. Okay, can you appreciate that?
Yes, sir.
Okay, this is supratubal races. Here, where I am putting this ball point, that is nothing but the tensor fold, which is separating the supratubal races from the anterior epitympanum. Okay, so you have to open this just like this, and I have developed that small pick, which is like a cobra. You just put it and open it. Just do this. Okay, like opening your maxillary sinus ostium. Okay, so this is here, and this is a beautiful anterior isthmus. Can you see that?
Yes, sir.
It's nicely going inside. That's an chorda, and here this is nothing but a posterior isthmus. You can see the stapedius tendon. This is a stapedius tendon.
Yes, sir.
Two crus also I am seeing. Processus cochleariformis here. I am going down now. Let's go give some angle. And that's a beauty. I can see both the crust. Look at this. I can see the facial too.
Yes, sir.
And I can see the pyramid. I can see the sinus tympani. Just I will point it out. Pyramid, from
Yes,
where
sir.
the stapedius is coming. Posterior crust. Above is a facial nerve. And this is nothing but this is a type 1, type A, sinus tympani. This is ponticulus, this is subiculum. In between, where my ball point is resting, this is a type A sinus tympani, superficial to the facial. Yesterday, I have completely demonstrated the facial. Facial is just 1 millimeter behind this. Which one? The pyramid. So this is a mastoid part. So I love going to the must parties. I is intracranial. Love is labyrinthine. Going is geniculate. So the geniculate will be here. And then 2 tympanic part, must, that is a mastoid part. And parties is nothing but a parotid. So sinus tympani, this is subiculum. This is the bone which is going to the round window. This is a rough landmark for the cochleostomy. Yesterday, Dr. Pradhan has shown you beautifully the cochleostomy, and he has put the electrode. So this is a fustis, okay, a rough landmark for this. And this is the hypotympanum. This is a plate which is separating the jugular from the mesotympanum, okay. Coming here, this is a funiculus. This is, can you see this small one? This is Jacobson's nerve. So the funiculus, Jacobson's nerve, where it will go, that is a processus cochleariformis. Just opposite to that will be cog, when I will take this all you have seen yesterday. And this is a protympanum here now, and this is a retrotympanum. I hope the idea is clear.
Yes, sir.
Okay.
Yes, sir.
So let's come and just try to peep. And for the sake of demonstration, also I will do some flush. Can you take? ये बहुत बड़ा हो या नहीं? डेक्सामेथा सुन, तब तक नॉर्मल सुन. एक बड़ा नीडल ले लेना, एक 1.5 इंच का नीडल है कोई भी. ये रूटीन वाला आपका इसका रहेगा, ये वाला नीडल इसमें का आईवी का नीडल जो है ये वाला भी मुझे चलेगा, ये नीडल जो है ये नीडल चलेगा, इसको भी हाँ इसको थोड़ा सा आगे, हाँ ये नया वाला तो क्योंकि इसको तुमने बेंड कर दिया। स्पाइनल नीडल है, बाईस है। Just for the sake of demonstration, how, because it's really a nice case, so how you do the opening, because something new for you, and this is called functional endoscopic middle ear surgery. Yeah. Doing that little bit extra for extra benefit. Dexamethasone ले लेना उसमें, बहुत बड़ा है ये, 18 नंबर है ये, छोटा इससे कम नहीं,
इससे तो फिर जो यहाँ होता है
वो पहुंचेगा ही नहीं वहाँ पे, नहीं वो तो पहुंचेगा ही नहीं। चलो थोड़ा सा स्ट्रेट करके छोटा कर दो, देखिए लेट्स सी विल मेक पुढचा फक्त एक बॉल पॉइंट, सक्शन बॉल पॉइंट, अरे आई तो दे सक्शन मिला नहीं, ठीक है चलेगा, इसको ही कर लेंगे हम। चलो नहीं ये ठीक, थोड़ा सा फक्त एवढं भी नहीं है, ठीक है इसको ही बेंड कर लेंगे। एक डेक्सामेथासोन ले लेना जस्ट। So I have just made this because we are creating the cannula for the anterior isthmus, where you can just put it. You have to do it very gently, because if you use the shoulder there, you can take out all the ossicles out. So you need to do it very gently. So try thinking that you are working in the eye. So be gentle. नहीं ठीक है, इसको कर दिया हमने, इसको बेंड कर दिया, मत करो ना। So just keep an eye on the anterior isthmus. So this is not a good one. So we need a nice this like that of your sac syringing, what the ophthalmologists do. So we are trying to create that perfect. Otherwise this traumatized. So you have to just go inside. That's all, and flush. Okay, so it's coming from both the sides. See, just 1 minute. Note this. Note the posterior isthmus.
Yes, sir.
See this. So it's so gently you have to do it. So by this you are putting some dexamethasone even in the mastoid. It's opening. It's reducing the inflammation. And you are opening the many channels. So I will unpack and we will harvest the tragal cartilage. Yeah, we have still not elevated the anterior margin. Okay, so that we will do. flag knife. Ball point. Angled circular. So just making that anterior pocket. Okay. Now our graft will go under this. Better. Now I will unpack and we will harvest the cartilage. Yesterday you have seen how I have harvested. So again now correlate with that. Try doing all these things because yesterday I told you the temporal bones are becoming rarer and rarer. Huh? This part of annulus we will just chop it out. So the ship head is there. We have developed the model on the ship head. The ear is almost similar. You can take all the cartilages there and try doing the ossiculoplasties and you can drill, you can do the canal plasty. Just now we carried out the endoscopic first ever, probably in the world, first ever adenotonsillectomy on the ship with a coblation. Believe me, it's a great learning tool. And on 25th, 24th and 25th May, we have again this dissection course where we will be teaching you two-handed endoscopic surgeries on the nasal septum. The dissectors will do the endoscopic septoplasty, learn some final some points of the rhinoplasty on the ship nose. Okay, so you all are invited for that. The date is 24 and 25th May of 2025. And I take this again opportunity, just put an, I will unpack, to invite you all for our innovative conference called SEOCon, that is a Society of Endoscopic Otorhinolaryngology conference. This society is for the all enthusiasts who want to work with the endoscope for the ear, nose and throat. It's not only for the ear. Okay, so we are trying to develop those techniques. So this time the faculties are my boss from Rostock, Germany, Robert Milinski, and then endoscopic single-handed Daniel Marcioni, then single-handed he will be demonstrating single-handed, I will be demonstrating two-handed ear surgery endoscopically. Dr. Parab will demonstrate nose and throat with the endoscope holder, and one and only the most talented guy of India is Satish will be there for demonstrating the microscopics and all other complicated cases. So you all are invited. The COCon is on 11th, 12th and 13th, 14th September. 11th will be the cadaveric dissection. Cadaveric dissection will be on human temporal bone, and it will be endoscopic two-handed as well as the microscopic. So already I think more than 80% seats are filled. So whoever interested, just contact and you are welcome. So let's harvest the cartilage. Take a 5 millimeter in your thumb forceps. This is what it is important to preserve for the cosmesis, and through just down this, go through and through. See this, like the way yesterday you saw.
Yes, sir.
This is cartilage is delivered. No, nothing hesitations, just go through and through. You can see the perichondrium on this side, perichondrium on that side, and the cartilage. If you want a perichondrium, you can just harvest the perichondrium too. That I do it for the army people, but here I want the cartilage. Why? Patient is having it for the last 9 years, and I will be just removing the perichondrium on one side. I will be using it. So it is around 0.7 to 0.8. That study we have published, that's the thickness of cartilage in Indian population. In a female, we have got a very thin cartilage. See, look at this. This is 0.7 millimeter approximately, because the age is 30. So age wise also we have decided that. And if you take a perichondrium of 100 micron, that is 0.1 mm, so it becomes a 0.6. So, and over the period of time, many of the chondrocytes are lost, and it becomes a nice TM. And believe me, I am using this cartilage as a primary graft for the last 2.5 decades in my private, and audiological outcome is absolutely no difference with the fascia. Only full thickness graft, don't use it, because many of the time patients say it's in fullness and some tinnitus, and little bit audiological outcome is inferior to that of fascia. I am a firm belief that you need some good material which will withstand the middle ear pressure changes, because middle ear is a dynamic cavity. Even if the patient suffers later on after the tympanoplasty with the recurrent CSYM, patient rushes to the clinician, takes a treatment, and again the eardrum is avoided the reperforation. So let's go near. You can harvest 1.5 by 1.5. We need hardly here 9 by 9 or 10 by 10. I have reached till the incisura terminalis. Okay. Now the Caesar. Give me the Caesar. Go to support. that's better. Look at the suction now. Suction लाव तिकडे आणि स्किन ला हे कर 15 नंबर प्लेन इथे सक्शन लाव आणि हे इकडे असं कर सक्शन त्याच्यात ठेव सक्शन खाली आणि स्किन ला हां. So now one inferior incision. You can go till the floor, no problem. Huh? And then at the junction, and you can take the whole of the incisura terminalis. Okay, see already we have dissected. That's all. See this. Okay. Yeah. So let's measure it. ASM grid. Twelve 1.5 by 10 sufficient for me. For the other side, I will take out the perichondrium. This is with the some fibrous tissue, so I will be taking out that. Before that, I will just close this with the 2 stitch. This is just one gauze piece. Yeah, dry though. So nowadays we are using a platelet-rich fibrin, and we are getting some extra results with that. The early recovery, the epithelialization is a fast, and now we are doing the study on PRF sheets. It's a patient's own blood. Just you have to keep one centrifuge in your OR and create those PRF sheets. It's there how to create that on my YouTube channel, and believe me, that works fantastically for even the mastoid reconstruction, and for such cases where it's a long-standing disease is there, it takes care of lot many things. So wherever those PRF sheets are kept, it takes the function of that tissue. So much more study need to be done, and we are doing that. We are trying the one project with deciding how much stem cells are there, and how much growth factors are there, like a PDGF, TGF alpha, and then and also epithelial growth factors. So if you provide this all on the surgical site, so the healing is fast, because all these things happens in the body during the healing. So if you provide some extra nourishment, I call it an extra nourishment, बहुत ही छोटी नीडल ले लिया, राउंड बॉडी ले लिया और ऊपर से कटिंग है और बहुत छोटी, बहुत ज़्यादा राउंड है और हाफ थोड़ा सा बड़ा मेरे लिए मिलेगा, दे दो 3-0, क्योंकि ये बहुत ही ज़्यादा कर्व्ड है तो मुझे खेलते बैठना पड़ेगा. इट्स वेरी स्मॉल. It's more than 3-4 circle.
पहुंचा दिया हमारे को.
इतना ये है कि वो बेंड भी नहीं हो रहा. Just one. all small things are very important. Now this is 3.5 circle needle, so I'm straightening it. ठीक है? Thumb force. Now it's better. पकड़ना दादा. So you have to use 4O or the 5O with a cutting needle and only a half circle. And need not to take out this, just 2 stitch. Thumb forceps. इसको रखो, बाद में अगर गलती से वो निकल गया तो लगाना. Gauze piece, dry gauze piece. So we'll peel off the perichondrium. और एक ड्रॉप बीटाडीन का डाल दो उसमें. Just peeling off the perichondrium. If you want to use like this, like as an island graft, I typically use this whenever I do the atticoantrostomy. So even like this you can use, so you get an extra graft. But here I don't want, I just keep, if I needed this perichondrium I will use. इसमें graft press में रख दो इसको. So now I will create the island for this. So this graft will be going like this, and I will create some nice island. Circular. काय जरा चालणार दिला असता सर हे काय just creating a island. This will come and lie over the canal. Making a circular disc. So now this is a nice circular disc. Now I will create a V for accommodating the malleus. Yes. छोटा देना रे दादा एक. Yes, because that will lie over the lateral process, huh? Nicely. Better? So let's go. So this is the graft. So you have to take a painstaking efforts like this, remove the perichondrium on that side, make it less than 0.6, and then the result will be great. Okay, just don't stuff the cartilage, whatever you have removed, just put it over the malleus like as a graft material. Okay. Any question? Ashwin bhai? Forse.
Any questions from the audience?
So, Ashutosh.
Yes, sir.
आया idea समझा?
Yes, sir. Yes, sir.
How to use this? Ball point. Yeah. Army patients, if you want, you can use the perichondrium. That perichondrium मैंने निकाल दिया है अभी. अगर छोटा perforation है, perichondrium लगा दो. अगर लगता है बड़ा perforation है, only with a small skin in the hair, you can harvest the temporal fascia and use for them. Otherwise, just harvest the perichondrium there only. You can harvest 10 by 10. दिखाओ उसको perichondrium कितना है अभी. वो देखो perichondrium. वो suicide. Even I can reinforce if something is there. Okay. Yeah. Graft. आशुतोष एक मोबाइल से मेरे 2-3 फोटो ले लेना, डालने के लिए अच्छा रहेगा सर्जरी करते हुए. From 02/08/72 2 अक्टूबर से बात करूँ बर्थ डेट. पीछे पीछे हाँ 2-3 ले लेना चाहिए. So try to adjust nicely that we should come there. Look at this. Now it's better. See this, how beautifully it is fitting.
Yes, sir.
Ball point. Now some abgel, we'll just see anteriorly and all. See, if you craft it very nicely, how that fits. Look at this.
Yes, sir.
Convinced?
Yes,
Yes,
sir.
sir.
Very nicely done.
See this. So you have to craft it beautifully and everything is nice. Look at this. V is perfectly fitting over that, and this is called a cartilage tympanoplasty. It's not all about just stuffing the cartilage inside, okay?
Yes, sir.
I hope you have been enlightened. Once again, I take this opportunity to thank you, my dear friend, Dr. Farooq, and my dear student Ashutosh,
Yes, sir.
who made me to invite here to this conference, and I really enjoyed the excellent dissection, and thanks to Dharmendra Kumar so for making HOD of it's really great, fantastic. You have a very good setup. Only I am sorry for you that you don't have a residence. So please bring the residents and your department will be flourishing, okay? Yes. लोगों को पकड़ के ज्वाइन करवा लो. Exactly. So आपके पास काम भी बहुत है and you can really very nice. I mean, it's from my heart I'm telling you, carrying out the cadaveric dissection is really a tough thing, and with these resources you have made it possible. I really appreciate you, okay? And keep this doing, because this is गुरु का काम, ये सबसे बड़ा पुण्य का काम है, ये याद रखना. जो बच्चा लोग सीखेंगे उसके जैसा और कुछ नहीं होगा. हाँ, यस. तो बहुत बढ़िया है, एंड कीप डूइंग दिस ऑल. साल में 2 बार करो, कोई टेंशन नहीं, लेकिन सिखाओ बच्चों को.
सर नेक्स्ट टाइम भी आपको बुलाएंगे सर.
Thank you. I will be happy always. I will be happy, really happy, and I really enjoyed the hospitality and thorough dissection. It was one of the best workshop I have done. Okay.
Thank you sir. हम लोग का डिपार्टमेंट की तरफ से कंटिन्यूअस रिपोर्ट रहता है कि हर एक साल वर्कशॉप हो जाए.
Yes, that's really nice of you, and you keep doing. So now look at this. Very meticulously bring this back. Okay, and we keep a PRF sheets over here, but we have not created. But I think एक बार फिर से देख लेंगे for the convincing. See, और कुछ करना है आशुतोष?
No, sir.
हो गए?
Perfect,
धर्मेंद्र
sir.
कुमार,
Yes,
ठीक है? अच्छा मैंने बिता दिया है, 2-3 दिन IV इंजेक्शन दे देना इसको, सर्वाइव हो जाएगा बढ़िया. और पोस्ट ऑपरेटिवली जस्ट गिव at least 10 days of IV antibiotic, this oral antibiotic for this patient, because it's a long standing disease. Antihistaminic at least for 1 month. And if you give a nasal spray, steroid spray, better, because patient is suffering with the bilaterally. So eustachian tube might be the problem for this. Okay. So
hello Mubarak.
Yes.
Why antihistamine for 1 month? What is the reason?
That's really a good question. So see, because this is chronic eustachian tube block, now we are trying to do for each and every bilateral CSOM. Whenever the patient comes, we try to do the nasal endoscopy, and we are trying to find out that block in the nasopharynx there. Many of the time the allergic changes there. Many of the time a small, even in the adult there are adenoids. So it is better to give an antihistaminic because it's an allergic source. Why? In case of the bilateral CSOM, okay, and there is no harm in that.
I have not prescribed a single antihistamine my whole of the life for any patient.
Because we have not treated the eustachian tube here, right? Because we are now meticulously trying to do in all cases nasal endoscopies. We are trying to see from the, here I didn't show you, but we are trying to see with the 70-degree in the eustachian tube, peeping inside the eustachian tube.
Sir, which type of nasal spray we use, like a fluticasone or azilastine combination, or your claim fluticasone?
Come again, I couldn't.
Yeah, in post-op advice, you say that we can give a nasal spray.
Yes.
So nasal spray means oxymetazoline or your steroidal spray with azilastine.
No, it's a steroid spray. Any of the steroid spray, because it takes care of a lot of allergy. See, nowadays the allergy is really tough problem, because due to the pollution, due to the dust, so much of pollution is there. So it takes care of many things in the nose, because we are not tackling these. So better to give, there is no harm in that.
Can we prescribe steam inhalation after some time? Steam inhalation to
steam inhalation का कुछ ज़्यादा ये नहीं है, but it will be better if you use nasal douching if the patient is allergic. If patient is proved allergic, I give nasal douches with the budesonide. Okay, that's a neti wash, soda bicarbonate, sodium chloride, and along with the budesonide. So for the proved allergy, and the patient if he is having the history of some polyps and all, so I give this nasal douches for at least 1 to 2 months.
Is there any role of prior nasal surgery to do a
no, unless and until, because it's only the eustachian, only the adenoid surgery gives a benefit, but you have to do the nasal endoscopy and see what grade of adenoids it is there, whether it is a closing or the eustachian tube end there. So even grade 3 plus adenoids must be operated even in the adult. So try doing the endoscopy in all the patients of the CSOM or the perforations, or when you are planning for the ear surgery, try peeping inside the nasopharynx and you will find some funny things, and that is what our next research we are doing. So a lot of things are happening in the nasopharynx, and that's due to the allergy. Adenoids are there in the adult, and then in such situation we convince the patient first to get adenoids done. We give a guarded result for these patients. If patient doesn't accept that we don't want a nasal surgery, then we give the guarded results for the patients. So you have to discuss all these things with the patients.
So there is any role of turbinate surgery or turbinate reduction?
Role of?
Inferior turbinate reduction. Inferior turbinate hypertrophy.
Yes, for the inferior turbinate hypertrophy, definitely it improves the airway. So for that only I am giving the nasal steroid spray. Okay. So many of the time, even if you just do the turbinoplasties and all, but again mucosa gets hypertrophy due to the allergy. Okay. So for such situation you need to have some topical agents even after doing the surgery. So I hope I have enlightened you with the two-handed endoscopic ear surgery with the sliced cartilage. Thank you very much, and I will just going to put 1 week of antibiotic. I prefer to put a bactigras, that is the medicated gauze paste which plastic surgeons use. है क्या bactigras? नहीं तो दे दो एक betadine का एक छोटा सा gauze piece दे देना. मोटा दे मोटी. जस्ट बिटाडिन ऑइंटमेंट का एक छोटा सा गॉज पीस, ऑइंटमेंट चाहिए, वो चाहिए, उसको लगा देना इतना, और ले लो, और थोड़ा सा बड़ा ले लो, और थोड़ा बड़ा ले लो, नहीं वो नहीं उतना ना, बस इतना इधर से कट करो.
सर वन क्वेश्चन,
जस्ट पैक जो है सिर्फ 5 दिन के बाद निकाल दो, ऊपर का जस्ट पैक, टाका निकालना नहीं है, एंड कुछ भी सक्शन नहीं करना है, छोड़ दो, ड्रॉप भी नहीं डालना है. अगर इफ यू फील सम डिस्चार्ज देन यूज द ड्रॉप, अदरवाइज आई डोंट यूज द ड्रॉप्स. ओके, एंड गिव द एंटीमा. Yes, you were asking something?
Yes, sir. For the endoscopic surgery, can we any in future of 3D endoscope in the ear endoscopic surgery?
Deviated?
3D endoscope.
Just please, can you stop? I am not able to hear.
Okay. 3D endoscope, sir. We are doing 3D endoscopic surgery in sinus surgeries. So, do you any role of 3D endoscope in ear endoscopic surgery? Role of 3D endoscope.
Role of?
Okay. 3D endoscope for depth perception in the ear surgery, sir.
Yes.
That's to look the isthmus, anteroisthmus, or any other.
Very good question. Very good question. And I have tried that. Storz 3D endoscope. The problem that they retracted it back because there was a problem in changing this rotation. There was one endoscope they brought with a 0 degree, 30 degree, 45 degree in that inbuilt, but it was not that good, so they have retracted. That's one. That was a good endoscope actually, but they have some issues. So that's why now there is this multiple endoscope in one, they have retracted. 3D, definitely it has got the role, okay? 3D endoscopy, and because you get some fantastic view inside, and we are trying to use the 3D endoscope. The problem is that Rubina system of this torch costs you crore. This, I think 1.1 crore or 1.2 crore. So still my patients are not paying that much for the ear surgery. So I
want to future perspective about the endoscopic ear surgery, sir.
Yes, it will change, but I'm definitely trying the Rubina system because it is established in the laparoscopy, in the gynecology and all. It's fantastic view. Okay.
Yes, sir.
Yeah. So when you will use this, I want to try it with the smallest endoscope, that is a 3 millimeter endoscope, and then the Rubina system, and then you will go moving inside, and the 3D, like you are sitting inside the middle ear and you are operating. It will be a fantastic view. I will use it. I will use it in near future. Yes.
Thank you, sir. Thank you, sir, for your nicely demonstrated type 1 tympanoplasty, sir.
Yes. Thank you so much for the invitation once again, and for the audience, for the patience. Yeah. Continue. पैक करो एंडोस्कोप, आशुतोष को दे दो, अपना सिर्फ बैग ले लो एम्प्टी. रफीक इज हैप्पी. ये वजन उठा के जाना नहीं. एनी इशू इफ यू हैव जस्ट लेट मी नो. बाकी इसको ऐसा ही रखना है, सिर्फ इधर ही तुम्हारा असिस्टेंट कुछ ना कुछ घुमाएगा, वो घुमाएगा, मैं तुमको दिखाता हूँ इमीडिएटली. सी नाउ इट इज दैट. अगर ये perfectly managed position में, if this is anti-clockwise, I just rotate it. ये दिखता है इसीलिए कुछ ना कोई लोग घुमाते रहते हैं अपने ओटी में. अब देखो क्या हो गया. अभी भी नहीं, इसको पूरा ऐसा घुमा के रख दिया. सो नहीं, ऑटो में ऊपर ही जाएगा ये, बिकॉज नाउ इट इज स्ट्रांग हो गया ये. ये हाँ, तो इसके लिए अभी क्लॉकवाइज, अभी बहुत क्लॉकवाइज करके रख दिया. यहाँ पे अभी भी बैलेंस नहीं हुआ है. दिस इज परफेक्ट बैलेंसिंग का मैंने लगाया हुआ था वो. दिस इज परफेक्टली बैलेंस. जिधर जाएगा उधर रुका. अभी अगर ये घुमाते बैठेगा तेरा असिस्टेंट ऐसा ही, इट विल फॉल डाउन. इट विल फॉल डाउन. इट विल फॉल डाउन. कुछ भी करेगा इट विल फॉल डाउन. हो गया. हाँ, तो इसके लिए अगेन ये फॉल हो गया पूरा. हाँ, अब एंटी क्लॉकवाइज इसको पोजीशन में ले लेके, तो उसको हाथ ही मत लगाओ. एक बार पोजीशन में लग दिया. और ये सब पूरे पार्ट सेपरेट हो जाते हैं. ओके, दिस इज मैनेज. तो थोड़ा बहुत इधर उधर नहीं हुआ, ज्यादा नहीं घुमाने का, थोड़ा सा इधर उधर कस कर, इट विल गेट मैनेज. और तुमको फिक्स में थोड़ा सा रखने का, इधर ऑटोमेटिकली टाइट हो गया, कुछ भी हिलेगा भी नहीं. ओके, कुछ लगा पूछ लेना. बाकी का तो ये स्क्रू 3 है मूव करने, उसका भी इस्तेमाल किया नहीं मैंने, क्योंकि फॉर ईयर के लिए ज्यादा मूवमेंट लगता नहीं. तुम अगर टॉन्सिल करना चाहते हो फिर उसको लगेगा ऐसा करने के लिए. सेप्टम करना चाहते हो, देखो वीडियो सब है मेरे इसके ऊपर. हाँ, सो सीओ कॉन के. सो will be there. Okay? Yeah. For the nose, ये पूरा इतना पोजीशन में कर देंगे नोज में डाल के. तो ऐसा इतना एंगल देना पड़ेगा. टॉन्सिल के लिए भी ऐसा रख के ओके. 4 mm एकदम झकास दिखता है. कुछ देखा ना. तो क्यों इतना ये करना है? सिस्टम स्ट्राइकर का 1/4 लेके बैठे हो और आंख से कर रहे हो. यस. एनेस्थेटिस्ट भाई का नाम क्या है? हाँ, एक फोटो लिया जाए. वेरी गुड, वेरी गुड एनेस्थेशिया. थैंक यू सो मच. हाँ, ये सब ट्रांसमिशन बंद कर दिया ना. बंद कर दो अभी ट्रांसमिशन. वो सब पूरा लाइव भेज रहा है उधर. अच्छा, एंडो होल्डर भी ले लो हमारा इनके साथ. अच्छा, मेरे कैमरे में भी एक ले लेना, बिकॉज ये जो फोटो है मेरे हॉस्पिटल के इस पे जाते हैं, मेरे इस कैमरे में ले लीजिए, बिकॉज वी क्रिएट द कोलाज एंड 020872 तू भी आ जा। अपने वो हॉस्पिटल की तरह नथिंग हो गया। थैंक यू। रफीक एंडोस्कोप कौन है? तो तेरे वाला असिस्टेंट की तरह। हाँ 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 यस प्लीज। वो अटैचमेंट भी ठीक से उसको रख लेना, कहीं घुमाना नहीं दूसरा अटैचमेंट। हाँ, इससे ही काम हो जाएगा, लेकिन अगर है तो उसमें